Hello, welcome to this evening's program, Is Lung Cancer Ever a Curable Disease with Treatment? Hosted by the Meyer Cancer Center, Office of Community Outreach and Engagement. My name is Kelly, and I'm the program manager for the office. I see some people have been here with us since Monday, so thank you, and thank you to those who are joining us for the first time tonight. I would want to take a moment just to orient you with the webinar functions. You're going to be using the Q&A function throughout the night for any questions, and we'll answer them at the end during our live panel. This evening's program is really robust. I'm very excited. We're going to be discussing the importance of lung screening from the caregiver and provider's perspective. We'll discuss different lung cancer treatments during clinical trials. And before opening up the Q&A session, we'll discuss biomarker testing, a word we'll be much more familiar with by the end of the night. November is Lung Cancer Awareness Month, and lung cancer is the leading cause of cancer death in New York City, affecting both men and women, smokers and non-smokers. Symptoms usually don't show up until the disease has reached advanced stages. The presentations you'll hear tonight are meant to inform you and empower you. So talk to your families and your friends, know your risks, and if you are eligible to get screened, get screened. Well, and while we encourage you to ask questions, we may not get to questions that are specific to your medical condition. Instead, we encourage you to consult with your primary care physician, especially if you're experiencing symptoms. And I'll share resources in the chat regarding primary care physicians at our sites and how to get connected with health insurance if you are currently uninsured. At the end of the evening, we'll announce the winners of our 3 $25 gift cards. So without further ado, we're going to start the first presentation. In 2012, the Mazzilli family lost a very spirited and respected family-oriented member to devastating lung cancer. The Fred L. Mazzilli Foundation was created by Freddie's close family members to raise awareness about the disease and to provide free lung cancer screening at NewYork-Presbyterian Brooklyn Methodist Hospital. Brooklyn native, former Major League Baseball player, and most importantly, Freddie's brother, Lee Mazzilli, will now speak to us about the importance of lung cancer screening and why he and his family founded the Fred L. Mazzilli Foundation.
Hey, Lee Mazzilli here. Hey, Brooklyn born and bred. I am here today to talk about New York Presbyterian and Brooklyn Methodist, our lung screening awareness, about having awareness of lung cancer. And unfortunately, we forget about that. And we forget how important it is to get a screening and get CT scans for our lungs. You know, we speak about breast cancer, pancreatic cancer, colon cancers, and lung cancer is more prevalent than all those cancers combined. But they have big awareness out there. I'm not taking anything away from those cancer charities. They're great charities, and we want everyone to contribute to those charities as well. But what I want to do is to just bring awareness to lung cancer screening. That's the most important thing. We want to just defeat all cancers if we can. But one of the things that I lost my brother a few years back to lung cancer. It was the most devastating time of my life. And, you know, to be honest, I wish I didn't have to make this video because my brother would still be here with me. But I am fortunate enough in his name to start a foundation, the Fred L. Mazzilli Foundation, for a lung cancer screening, which is so important to us. And the reason why I started this foundation, my sister, my wife, and my family, my kids, we wanted to do something in his name. He was so well treated at Brooklyn Methodist Hospital, and especially Dr. Saylor. He is a saint. He is a gift from God. The time that he spent with my brother, I cannot even tell you how much time. The love that he has, the caring that he has, not only for my brother, but for the people of Brooklyn. And that's the key. This man is one of the reasons why I started this foundation. So what I am asking for all of us in the Brooklyn community is to get screened, okay? Go and ask your doctor, oh, doctor, you know, I have an important colonoscopy. You know how we get that, how we get our PSAs. We ask our doctors that, but we do not ask for CT scans, get lung screening scans. It's important that we do this. So I ask all of you in the Brooklyn community, go out, get your free lung screening test. We, as the Fred L. Mazzilli Foundation, we provide this to the people of Brooklyn. And I am so happy to work with the New York Presbyterian Brooklyn Methodist Hospital to be involved with us. So if we could save one life, we did our job. And that's the most important thing. So help us. Go to the foundation, fredlmazzillifoundation.com. And if you can help us, we welcome you all. We are a small foundation. We are a mom and pop foundation. My wife, my kids, we lick the stamps. We write the envelopes out. You know, so if any help that we can get from you, that's great. But you got to get the lung screening test. So I just say to all of you, make sure in closing, wear your mask, put your gloves on, wash your hands, do the things that we need to do to stay healthy and live a long life. I give you my love to all the people in Brooklyn and to all my friends. I'm just so happy that I am able to contribute just a little bit to the Brooklyn community and to the Fred L. Mazzilli Foundation. Thank you all. God bless. Happy Thanksgiving. Have a great Christmas and Hanukkah. But most importantly, stay healthy. And I hope to see you soon at the hospital for our screenings. Thank you so much.
Thank you so much, Lee, for starting off the night. And what a beautiful and touching way to honor your brother's legacy. I know he talks a lot about the Brooklyn community, and of course, that's where he's from and where his foundation is set up. But we're also going to share resources at the end of the night to where you can get screened at Queens and Manhattan. We really want to make sure we're thinking about the New York City community as a whole. So next we have we're going to be discussing the importance of lung cancer screening. Brooke O'Neill will be joining us, and Samantha Vigada as well. Brooke is a registered nurse at NewYork-Presbyterian-Weill Cornell Medicine. She's a program director for the radiology consultation services, which aims to improve quality of care by promoting patient-centered and evidence-based radiology at Weill Cornell Imaging at New York Presbyterian. Samantha is a nurse practitioner. She promotes lung health by seeing patients for lung cancer screening and incidental lung nodules, as well as tobacco cessation. Thank you so much for joining us, Brooke and Samantha, and we'll be listening to you all talk about the importance of early detection.
So my colleague Brooke and I are happy to be here today to discuss lung cancer and the importance of early detection. The purpose for this presentation is to increase awareness and education regarding lung cancer screening by discussing evidence-based approaches utilized at Weill Cornell Medicine. Objectives include to discuss the risks and benefits of annual low-dose screening in high-risk populations and review frequently asked questions about lung cancer screening. We have formatted this presentation in the Q&A format, so if you happen to have a question that we do not discuss, please feel free to reach out after the presentation or by contacting us privately via the information we provide at the end. So first and foremost, what is lung cancer screening?
Thanks, Sam. So as many of you may know, lung cancer is the leading cause of cancer death for both men and women worldwide. And lung cancer screening is something that can make a dent in this statistic. Lung screening is a regular preventive health check that uses a low-dose CT to examine the lungs of high-risk individuals year to year and looks for changes to detect lung cancer at the earliest stages. This exam has been given a grade B recommendation by the United States Preventive Services Task Force. Under the Affordable Care Act, that means that private payers actually cover this exam with no cost sharing to patients, so fully covered. Lung cancer screening is also endorsed by the Centers for Medicare and Medicaid Services, or CMS. So what evidence supports lung screening, Sam?
Great question. So the National Lung Screening Trial, or also known as the NLST, compared the use of a low-dose CT scan to a normal chest X-ray in over 50,000 people at high risk for lung cancer. And the study was actually ended early because there were significant benefits that were found in having an annual low-dose CT scan. It also, unfortunately, identified some potential limitations and harms, which we will discuss in more detail in just a little bit. The impact of screening may also vary depending on how similar you are to the patients who were used in the NLST trial. So what are the benefits of lung cancer screening?
The main benefit of screening for lung cancer is a lower chance of dying from lung cancer. In that national lung screening trial, annual screening with low-dose CT for 3 years reduced lung cancer-specific mortality by 20% in the high-risk population, as opposed to chest X-ray screening. Said another way, 3 in 1,000 fewer people died from lung cancer. And more recent studies have shown it can actually reduce mortality up to 61%. One key point here is that lung screening does not actually prevent one from getting lung cancer. But when lung cancer is detected at an early stage, before it spreads outside the lungs, there are more treatment options and it has a higher cure rate. One thing to highlight is that I use the word cure because in many cases, when lung cancer is detected early enough, it can actually be cured. And that's something and a message that I really want to be spread during Lung Cancer Awareness Month. So early detection saves lives is an expression that pertains to many different cancer screening types, not just breast cancer, colon cancer, but lung cancer as well. Early detection saves lives. So Sam, what are the harms of lung cancer screening now that we've discussed the benefits?
So there are some harms or potential limitations of lung cancer screening. One of those are false positives, which is being told that you have a condition that you don't actually have. Another is radiation exposure, which we'll discuss in a little bit more detail soon, and anxiety. This could be a very anxiety-provoking exam, but it is important for you to know that we are here to help you throughout the process and help alleviate any stress that you might encounter along the way. So how do I know if I'm eligible for a CT lung screening exam?
Great question, Sam. It's really important to note that annual low-dose CT is recommended only for people who are at high risk for lung cancer. As much as we would love to be able to screen the whole population, there isn't evidence to support that at this point in time. Currently, the guidelines for screening are individuals ages 55 to 80 years old, or 55 to 77 for those with Medicare and Medicaid, current smokers or former smokers who have quit within the past 15 years, those with a heavy smoking history equivalent to at least 30 pack years. And pack years sounds like a complicated calculation, but it's really pretty straightforward. You multiply the number of packs per day you've smoked times the number of years you've smoked. So for example, if I've smoked a pack per day for 30 years, that's 30 pack years, or half a pack a day for 60 years would be 30 pack years. It's also important to know that individuals need to have no signs or symptoms of lung cancer in order to be screened. If somebody has signs or symptoms of lung cancer, they really should be seeing a provider and see if diagnostic testing is more appropriate for them. During our consultation, we're happy to help advise about that. One thing to note is that as of July 2020, the United States Preventive Services Task Force has drafted a recommendation which would actually lower the age of adults to start screening to 50 rather than 55. So we hope to see this finalized in the coming months. Sam, for the next question, I'm wondering what I should expect for my screening appointment.
So first, I think it's important to note that patients can be referred to our program by their primary care provider or a different physician, but also just by self-referral. So please feel free to reach out to us directly if you do think you meet any of these criteria. Prior to undergoing the screening, you should engage in a shared decision-making consultation with either your provider or our program coordinator. This is the perfect time for you to ask any additional questions you might have about screening or the process in itself. For the low-dose CT scan, you'll be taken to an exam room and asked to lie down on a table, which slides through the scanner. You'll be asked to hold your breath for 5 seconds, and then they'll take the picture of your chest. This is a completely painless and quick process. Once we have the results, these will be communicated to your doctor and then communicated to you. It's also important to note that lung screening is a process rather than one single CAT scan. So it's important to follow up annually and also follow up on any additional abnormalities that we might see. During the shared decision-making consultation, we also use this time to talk about smoking cessation, and we can help coordinate and schedule any future counseling visits. A question we get a lot is the radiation dangerous?
I can feel that one, Sam. So the screening CT is called a low-dose CT scan because it utilizes less than 20% of the radiation used for standard diagnostic chest CTs. This lower radiation dose is equivalent to about 4 to 5 months of naturally occurring background radiation just living on planet Earth. So the scan is a little bit more than a mammogram or a chest X-ray, but it's certainly much less than other types of CT scans. So in this case, for those who are at high risk for lung cancer, the benefits of the scan really outweigh the small risk of radiation. For our next question, some individuals might be wondering, how much does it cost? And we touched on this a little bit, but Sam, can you provide a little more information?
Definitely. So low-dose CT screening for people who are at high risk for lung cancer, so those patients who meet the criteria that we discussed earlier, is covered fully by Medicare, Medicaid, and private insurance. If you happen to fall outside of those guidelines, please feel free to reach out to us about specific coverage and pricing information. So now that you've had the exam, what happens if we find that abnormality?
All right, I'm going to start by reviewing the common abnormalities that we find on chest CTs. So the first finding that is very common are lung nodules. And that's actually what we're looking for in this scan. Lung nodules are spots on the lungs that most of the time are completely benign. They can be caused by infections, scarring from prior infections, a whole range of things. However, a small percentage of lung nodules could be cancerous. So depending on the size and the composition, some of its features, our radiologists will recommend follow-up accordingly. The recommendations can range from a short-term follow-up chest CT, for example, in 3 to 6 months after your original scan, or something more significant like a PET CT or a biopsy for tissue sampling. And I want to let you know that our program coordinators, such as Sam, our nurse practitioner, is there to guide you throughout that process. If an abnormality is found in your scan, it's evaluated by our multidisciplinary team of experts who really make an individualized and evidence-based recommendation for that follow-up. Now I'm just going to touch on 2 other common abnormalities that we see on CT screens. First is emphysema, which is damage to the lungs. If we note a significant amount of emphysema, it might be appropriate to follow up with a pulmonologist or a lung specialist. Also, we are able to view some of the features of the heart and look for coronary artery calcifications. This abnormality might indicate the need for follow-up with a cardiologist, and we're here to guide you through the process and place any necessary referrals with our great collaborators at Weill Cornell Medicine. So for our next question, I touched on lung nodules, but if I've been told I have a lung nodule, what should I do? And maybe Sam, you can highlight, so some people through the screening program have screen detected lung nodules, but what happens if you have a lung nodule from another type of exam?
Yeah, so lung nodules are very common to have. Even people who have never smoked before can have these nodules or spots in the lung. Each year, over 150,000 people are diagnosed with a lung nodule, and a lot of times those are detected incidentally, meaning we're not looking for them, but we're doing an exam and happen to see one. So if you happen to have one of these lung nodules but don't meet those guidelines for a lung screening exam, we can provide an individualized assessment and help create a follow-up plan that's best suited for you. So besides getting screened, what can I do to reduce my risk?
This is one of my favorite questions. So regardless of your screening decision, the best way to reduce your risk of developing lung cancer is to never start smoking or to quit smoking. In fact, avoiding tobacco is the best way to lower your chance of suffering or dying from a variety of diseases, not just lung cancer. For example, emphysema and heart or vascular disease. So we know that it is really, really difficult to quit smoking. We encourage discussion with our smoking cessation counselors. Sam is one of them, and she really offers individualized support. I want everybody to know that low-dose CT screening for lung cancer is not a substitute for smoking cessation, and we're here to support you during a quit attempt. We also know that a combination of behavioral counseling and FDA-approved medications can assist to help patients to quit and stay quit. We know that supportive programs and medication can help a person successfully quit, increasing that quit rate from 5% to 40%. So moving on to just summarize some of the things we've talked about today. Screening with the use of low-dose CT reduces mortality from lung cancer. It's an underutilized tool, and increased awareness and education is needed in order to increase use amongst our highest risk individuals. Quitting tobacco is the most powerful way to lower the chance of dying from lung cancer. And last but not least, early detection saves lives. I'm going to say it one more time, early detection saves lives. So here's a list of some of our contact information for both the lung cancer screening program at Weill Cornell as well as the tobacco treatment program. One thing to highlight is that you do not need to be a screening patient to call us up for tobacco treatment services. We're happy to help find you resources either way. Sam, is there anything else you want to add?
Again, we're going to say it one more time. Early detection saves lives. So please feel free to reach out to us if you have any questions or concerns. We're happy to help, and we hope to hear from you soon.
Thank you.
What is that one more time? Early detection saves lives. Thank you so much, Sam and Brooke, for that wonderful presentation regarding the importance of lung screening during this time or at any time. And thanks for sharing with us who may be eligible for screening. Again, we'll share some resources at the end of the presentation. If you have any questions, go ahead, put them in the Q&A box now before you forget them. And we'll go to our next presenter. So I have the pleasure of introducing Dr. Brendon Stiles, who's a thoracic surgeon at New-York-Presbyterian Hospital, Weill Cornell Medicine. Dr. Stiles has a patient-first philosophy and considers it an honor and a privilege to take care of people. In addition to his duties at Weill Cornell Medicine, Dr. Stiles also serves as the chair of the board of directors of the Lung Cancer Research Foundation, a national not-for-profit focused on lung cancer research and advocacy. Dr. Stiles will now be discussing Lung Cancer Treatment 101.
Hi, I'm Dr. Brendon Stiles. I'm an associate professor of cardiothoracic surgery here at Weill Cornell, New York Presbyterian Hospital. And I'm here today to talk to you about Lung Cancer 101. What do you need to know about lung cancer? And more importantly, how much progress have we made in lung cancer? So it's important to recognize that there's a whole spectrum of cancer. And how anxious you should be and how worried you should be about a certain cancer depends on the extent of it, certainly. There's lots of terms that get thrown around. Believe it or not, we all have mutations in our body and normal tissue in our body. Only a handful of those will go on to become dysplastic, meaning they show abnormal changes, or to even early non-invasive cancers to invasive cancers. And this is the same for lung cancer as it is for many other cancers. Imagine this as a colon polyp or as a ductal carcinoma in situ in the breast. This idea that some cancers haven't yet invaded and still are no threat to a patient versus an invasive cancer that can invade through the tissue membranes and into the bloodstream. Lung cancer runs this whole spectrum of disease, and increasingly we're able to identify some of these things even from the CT scan, which a patient may get. I always like to put things in historical perspective. I think it's really remarkable to look back just over 100 years ago and think, well, what was lung cancer then? This is a remarkable paper from a doctor named Dr. Adler, who worked here in New York City. It was published in 1912. He talked about the world's entire experience with lung cancer, which was 374 cases at that time. And Dr. Adler made the startling conclusion that on one point, there's nearly complete consensus of opinion that primary neoplasms of the lung, or lung cancers, are among the rarest forms of disease. And he opined that very few physicians would even encounter this disease. It was so rare. Well, my, how things have changed. This is 2020 data, and I think it's really sobering to look at this. Lung cancer is the second most common cancer in men after prostate cancer, and it's the second most common cancer in women after breast cancer. Probably even more remarkable and more important to society is that lung cancer causes more deaths than any other cancer in men, more deaths than any other cancer in females. That's often unexpected as people think about prostate cancer and breast cancer. But if you step back and look at the numbers, lung cancer in itself causes more deaths from cancer than prostate cancer, breast cancer, colon and rectal cancer combined. It really takes a staggering effect on patients and on their families and on our healthcare system. It's really important to acknowledge that lung cancer is not just one cancer. In the old days, they may have said, a person has lung cancer. But now we know there's non-small cell lung cancer, there's small cell lung cancer. Even within non-small cell lung cancer, there's adenocarcinoma, squamous cell carcinoma, large cell carcinomas, neuroendocrine tumors. And that increasingly has really critical implications because those different subtypes are treated in different ways. No longer do they lump everything in together and just treat it as lung cancer. We have very specific treatments for each different type of cancer. Appropriate to that is this idea of molecular classification of lung cancer. Yes, a cancer may look different under the microscope, but even more importantly, it may have a different mutation which started in the cells in the lung, which are now driving that cancer, keeping it alive, encouraging it to grow. Things like EGFR mutations, KRAS mutations, ALK translocations. We're starting to think of cancer as a molecular disease, and that maybe cancers with an EGFR mutation of the lung, of the colon, of other things may all be treated more in one way than cancers of the lung. But it's increasingly important to understand what's the molecular classification of a patient's lung cancer. I think it's also really important to understand that although lung cancer rates increased as a direct consequence of smoking tobacco, that never smokers can get lung cancer too. I think the problem with the smoking idea is that there's often a certain amount of stigma, a certain amount of nihilism that's associated with smokers who get lung cancer. As I mentioned before, those ones are the patients who predominantly have the most deaths. And there's some sense, hey, they brought it on themselves, they smoked. That's just simply not true. In my practice, about 30% of the patients that I operate on are never smokers, and the vast majority stopped smoking years and years ago. We know that there's other causes of lung cancer, whether it's environmental, whether it's genetic features, radon exposure, indoor coal and wood in the developing country, cooking oil vapors. We don't really know why never smokers get lung cancer. It's probably some combination thereof, but I think it's really important to acknowledge that it's not just a smoker's disease. Important to acknowledge that it's not a patient's fault if they smoked in the past, or even current smokers. That's an addiction. We're going to treat all patients with lung cancer the same. What symptoms do lung cancer patients have? Certainly, we would love to find your cancer or a patient's cancer before they have symptoms. Once a patient has symptoms, it becomes more challenging to treat. But these are the types of symptoms that lung cancer may promote. And you can see they're really quite nonspecific, which makes the diagnosis hard to arrive at, which is often why patients present with advanced disease. Chronic cough, potentially coughing up some blood, wheezing, which may be attributed to asthma, chest, bone pain, musculoskeletal pain, shortness of breath, difficulty swallowing, unexplained weight loss. These are challenging and pretty non-specific symptoms, and particularly think about it in the COVID era, in which there's so much respiratory disease with COVID. It's easy to have something like this and to blow it off. But I think persistent symptoms really mandate a workup and a careful workup. Even in never smokers, as I showed you, never smokers can get lung cancer. It's important to be thoughtful of that, to understand that, and to really work up symptoms when appropriate. How do we think about cancer? Like any cancer, understanding the stage is really the key. The stage allows us to understand the expectations for the patient, but it also allows us to guide the treatment for the patient. Like most cancers, like all cancers, frankly, we stage using a very specific system. That's called the T, the N, and the M. The T stands for the tumor and is often referring to tumor size. The N stands for the lymph nodes, and the M stands for metastasis. As you can see here in the lung, there's quite a variety of ways it can present. A little small nodule out on the edge of the lung, early T1, can present with a nodule invading the lining, a more central nodule, one that's gone into the ribs. Those are all variations of the T stage. The N really talks about the location of the lymph nodes. N0, hopefully, meaning there's no lymph nodes involved. N1, the little lymph nodes out in the lung. N2, one's in the middle of the chest. N3 is lymph nodes outside the chest. Obviously, what we don't want to find is the M. Has the thing metastasized anywhere else? Lung cancer can go to the brain, to the liver, to the adrenal glands, to the bone. Obviously, this has different implications than an earlier, more localized cancer. Because understanding the stage is so important, a lot of patients will go through staging tests. Those include things like CT scans, PET scans, to determine if the cancer is spread anywhere, brain MRI. Sometimes that will lead to invasive staging tests, like what's called an EVIS to biopsy lymph nodes, sometimes a CT-guided biopsy to biopsy potential metastases. But just like understanding the type of lung cancer and the molecular pattern of lung cancer is important, really understanding the stage and doing a good job of staging is critical. And that's because stage really guides how we treat lung cancer. You can see here that really there's quite different treatment. Early stage cancers, like most cancers, are generally treated with surgical resection, sometimes these days with radiation therapy. Middle stages are typically treated with combination therapy, surgery and chemotherapy, surgery and radiation and chemotherapy, just chemotherapy and radiation therapy. There's a variety of ways, and it really does critically depend upon the stage. Once we get to stage 4 disease, that's where we typically are away from what's called local therapies, surgery and radiation, and move into systemic therapies. It's therapy that goes throughout your body, throughout your whole system. And that's things like chemotherapy, targeted therapy, or in this day and age, immunotherapy. But I think if you step back and you look at this chart and you say, well, look, how can I do the best? Stage 1 does the best, right? And 5-year overall survival is even higher than this probably now for early stage 1, treated with surgical resection, no other therapy. So arguably, we could perhaps make the biggest impact if we just found lung cancer early. We should be able to do so, right? As you probably know, screening exists for a lot of cancers. For breast cancer, there's mammography. For colon cancer, there's colonoscopy. For prostate cancer, there's PSA and prostate exams. What a lot of people don't know is that a readily available screening test exists for lung cancer as well, and it's just a simple CT scan of the chest, a low-dose CT scan. That's been shown in large randomized trials to decrease your chances of dying from lung cancer if you get a CT scan. And that's pretty remarkable, I think. Unfortunately, the rates of uptake of CT screening for lung cancer are lower than the rates of other cancers, and there's probably a lot of reasons that go into that, despite it arguably being an easier test. But I like this graphic because it shows the potential if we did screen eligible patients, and that's generally patients who have a history of smoking, who are over age 55, how could we do? How many lung cancer deaths could we avoid? To put this in perspective, right now we're probably only screening about 10% of eligible patients for lung cancer. If we got that rate up to just 25%, just 1 in 4 patients, we could save almost 35,000 deaths from lung cancer. If we did as well as these other cancers that all have screening rates that are higher, prostate, colorectal, breast, cervical, look at the numbers of deaths we could avoid. And if we could screen all the patients who are eligible, by 2030, we could save almost 140,000 lives. That's pretty remarkable, and I think it really mandates that patients should ask their doctors about screening, ask who's eligible, ask about the risks and the benefits of screening, how often do you find a false positive, something that you don't want to see, and really understand the consequences. But I really encourage active discussions about screening, particularly for former smokers. We know that screen-detected cancers can very often be treated with surgery, surgical resection alone, and not need chemotherapy or radiation or other things. Surgery has certainly come a long way. This was the surgeon who did the first pneumonectomy, removed an entire lung from another physician. Now we can take out less lung. Instead of doing it through an open incision between the ribs, we can often do it through little small keyhole incisions. It's called VAT surgery or thoracoscopic surgery, where we're watching on the screen and operating through incisions that are really just less than an inch. And even nowadays, sometimes robotic surgeries, the idea where we have a very sophisticated robot operating through those same small incisions, really guided by the surgeon who's sitting at the console, working all of those arms with an assistant at the bedside. The technology is amazing. Our ability to get patients through safely through anesthesia, through their hospitalization has really improved dramatically. And we know that we can cure early stage lung cancer with surgery. How about the other side of the coin? As stage advances, we need more different types of treatment. And that's evolved remarkably as well. There's been advances in almost each of these stages as we've looked over the last couple of years. Most patients present with stage 4 disease, metastatic disease, and that's perhaps where we've arguably made some of the greatest advances in cancer over the last decade. Lung cancer now has options like immunotherapy, targeted therapy that can treat these patients, and instead of a 5-year overall survival of 5%, pushing it out to 15% in large series, to individual series with individual drugs, 30%. We don't know what the ceiling is yet, but we know that we're doing better, that we're keeping patients alive longer, and some are even whispering about cures potentially in stage 4 patients. What does that look like? This is certainly one of the most daunting slides I've ever seen. It's by a Spanish medical oncologist, but this should really give you an idea of everything that's happened in lung cancer. No longer is it just one disease with a line going straight to chemotherapy for stage 4 lung cancer. This is the idea that lung cancer is not one disease, it's many diseases. It's EGFR lung cancer, ALK lung cancer, ROS1 lung cancer. All of these drugs and others, and there's about 7 different targets for non-small cell lung cancer, have very specific targeted therapies that can be used very effectively, even for patients with stage 4 disease. Many of these drugs are pills rather than infusions of chemotherapy the patient can take in his or her own home. They're drugs that often have less side effects than chemotherapy, and that often have significantly prolonged survival compared to chemotherapy alone if a patient has one of these mutations and can be treated with the drugs. On the other side of the coin is immunotherapy. And that's the idea of using drugs to allow your body's own immune system to fight off the cancer. You release a brake on your T cells so your own T cells can attack the cancer. Immunotherapy has really revolutionized cancer therapy. It started in melanoma, but in many ways, lung cancer has become the poster child for immunotherapy. Now it's offered to patients with adenocarcinoma, with squamous cell carcinoma, with small cell carcinoma. And it really has changed the paradigm of how we treat and how we think about patients with stage 4 disease. It's an amazing time to be a part of this field, and there are amazing options for patients with all different presentations of disease. And what's that led to? I think really lung cancer has been at the forefront of the overall cancer death rate, which has dropped 27% over 25 years. This publication got a lot of headlines in the popular press, and deservedly so. I think the decrease in cancer mortality was largely attributed to decreased smoking rates and advances in early detection and treatment. But there's also been a suggestion in recent publications that it's the identifying the molecular drivers and treating for the targets is decreasing the mortality rate. And this is even before widespread use of immunotherapy, in which I expect that we'll continue to see these death rates go down. Our goal was to really make cancer a chronic disease that can be treated indefinitely, that doesn't kill people. It doesn't take that staggering toll that I described previously with lung cancer. And this is a personal example for me. This is my father, Kenneth Stiles. He sadly died of lung cancer 15 years ago. He died, though, at a time when we didn't have lung cancer screening, we didn't have targeted therapy, we didn't have immunotherapy. And to put that in perspective, that was just 15 years ago. We've made remarkable progress since that time. I know that my dad would be proud of that. And I know he would suggest, as I do, that everyone be an advocate for him or herself, be an advocate for your family members, ask about staging, ask about molecular testing, ask about the best treatment options. There's so much happening in the lung cancer world. You almost have to go to an institution or place or a doctor who has expertise in lung cancer. It's a good problem to have. There's so many things to keep up with. We will be that for you here at Weill Cornell and at New York Presbyterian Hospital. And I think, in my opinion, there's no better place to come for lung cancer treatment. Thanks, and I'll leave you with this, and good luck, and thanks for allowing me the privilege to speak to you.
Thank you so much, Dr. Stiles, for that really great presentation. I know I learned a lot, and thank you for sharing a personal story and what sort of motivates you every day to continue to do the work that you do. Thank you for that. I think you brought up some great points. Lung cancer is often stigmatized, And I think that's because we assume that only smokers get lung cancer, but as we can see, a lot of people who do not smoke have the chance of developing lung cancer. And thank you to the person who's asked that question. We will talk about that a little bit more during the Q&A session. Another thing that Dr. Stiles and Brooke and Lee and Sam really made sure to talk about is to ask for lung cancer screening. And you want to make sure that you are empowered, that you have the education and the tools to advocate for your personal health. And not overstate that you really do have to advocate for your health and make sure that you make decisions in conjunction with your physician. And lastly, what I really learned from that, we've made a lot of headway when it comes to lung cancer treatment. And I think a lot of that may be due to clinical trials, which brings us to our next presentation. So Dr. Giaccone will be speaking with us. He joined New York Presbyterian as Chief of Thoracic Oncology and the Associate Director of Clinical Research at the Meyer Cancer Center. Providing the best possible care has always been a goal of his in his career, and that has meant deep involvement in research. So Dr. Giaccone will be discussing the importance of clinical trials in lung cancer treatment.
Today, I'd like to talk to you about clinical trials. The definition of clinical trials is research studies that test new treatments or interventions to see how well they work in people, in human beings. It is important to say that most cancer treatment are really available because of clinical trials. All of these cancer treatments actually had to go through a rigorous process before they are approved by the Food and Drug Administration, the FDA. They are designed to answer specific questions about the safety, the side effects of the new treatment, and then the benefit-risk ratio. Of course, if the benefit is large, one may accept higher risks, higher side effects. But if the benefits are relatively small, then the risks have to be also very small. And these are things that have to be taken into consideration before a new treatment is approved. There are two main categories of clinical trials. The first one is non-therapeutic trial that tests questions about patient experience or outcome. These can be diagnostic trials to understand an individual person's disease, where you look, for instance, at new way of diagnosing a new cancer type or a new disease. There can be screening trials that test the best way to detect cancer. An example is, for instance, a CT scan of the chest to test whether a heavy smoker has developed lung cancer. There are quality of life trials, also called supportive care trials, that explore ways to improve comfort for people who live with cancer. And this can be surveys or focus groups. The second category of clinical trials are therapeutic trials that test questions about an intervention. This can be cancer treatment trials that test new drugs, radiation therapy, surgery, or other therapies, for instance, a vaccine, immunotherapy. And then we have cancer prevention trials that that test new ways to prevent cancer in people who never had it. And this can be done through drugs, can be done through vitamins, vaccines, changes in the lifestyle. For instance, in lung cancer, there have been several studies looking at vitamins and other supporting measures to see whether they could prevent cancer, especially in heavy smokers. Probably many people of you have heard and when asked are concerned about the use of placebos. Placebos are inactive and non-toxic treatments that are usually employed if the effect of the new treatment can be confounded with the standard therapy to which it is compared. So in any case, people are always told whether the study uses a placebo. However, sometimes the patients may not be told if he or she received the placebo. And this is the case of blinded study. There are also double-blinded studies where not only the patient doesn't know if he or she received the placebo instead of the active treatment, but also the doctor doesn't know. These studies are really very important. They are usually phase 3 studies, the more advanced phase of experimentation, where a new treatment really has very little in terms of side effects. And therefore, in order to be able to have a definite answer whether the new treatment is better than what was used before, you need a placebo-controlled comparative trial. The phases are shown here. Before going into patients, into humans, there have to be a number of preclinical studies. These are done usually in cell lines and then animals, and the most studied animal is the mouse. Once there is enough information about side effects and potential activity of the new treatment, then it goes into patients. There's a phase 1 that is the first phase where the new study is tested. This is usually done in patients who have received prior treatments and for which treatment doesn't work anymore. The main aim of phase 1 is to look at safety of the medication and to come up with a dose which is safe, doesn't have too much toxicity, and could potentially be active. It takes several months to a year to do a phase 1 study. Then the drug or the new treatment goes into phase 2 testing. This is now testing at a dose that is potentially effective and testing it in subgroups of patients that are well defined. For instance, patients with lung cancer or breast cancer. For phase 2s, it takes about 2 years. And the next phase, if the phase 2 is positive, then it would be comparing the new treatment with what was standard before. So this is a comparative or phase 3 trial. And in this case, it may require a placebo if the new treatment is really non-toxic. Phase 3 trials may be very large and they may have even hundreds of patients, and it may take 2 to 5 years. If the phase 3 is successful, then usually FDA gives an approval, which can be sometimes conditional. And the studies that are done after the approval are called phase 4. It is really to obtain more information on large number of patients about activity as well as toxicity. It is important that in clinical trials there are several different populations being tested because drugs may work differently based on age, sex, and sometimes even race. For instance, a child's dose of Tylenol is different from an adult's dose, just as a simple example. And a drug that may not work in one population may be life-changing in another population. So we really need to have enough diversity in the clinical trials to be able to really achieve the best results we can. There are several barriers to participation in clinical trials. Probably a common one, maybe the most common one, is mistrust. Mistrust in general in research. It can be cultural beliefs that a new treatment may be against religion, for instance. But on the side of the doctors, of course, what is in the protocol is what really is the most important potential barrier. The eligibility criteria in many of these studies are quite strict, and the presence of comorbid conditions may limit the entry into the study. Patients may not be invited to participate because maybe the doctor didn't know there was a study available, and cost or not having an insurer may be an issue in participating in clinical studies, as well as linguistic differences. Although most of the studies will have the informed consent translated in different and most common languages. And finally, lack of awareness, both on the medical side as well on the patient side. Clinical trials are really very important because they are the crucial step in finding new and promising ways to improve treatment. And most of the practice changes, advances in the treatment of cancer really have come through clinical trials. Participating in clinical trials also allows the patients to have access to new drugs or new treatments before they become widely available, in essentially before FDA approves them. And diversity in clinical trials, again, is important in order to be able to see differences in safety in different patient populations and differences also in activity. And last but not least, participating in a clinical trial can not only help you, but can also make a valuable contribution to cancer research, helping other people diagnosed in the future. So I show you now actually three examples, 4 slides of successful clinical trials. This was a phase 1 study of a new drug called crizotinib in ALK-positive non-small cell lung cancer. This is a particular subtype of lung cancer. It's about 4 to 5% of all the lung cancer. And this is so-called a waterfall plot where each bar is one patient. And if you see the dimension of the bars under the 0, that means that the tumor has shrunken in size. And if it is less than 30%, then this is called a major response. As you can see here with this drug, the majority of the patients had actually a decrease in their tumor size when they were treated with this new drug, and 57% had a decrease that was at least 30%, so it was a major response. This is not common in phase 1 studies, but it is what brought to the registration of this new drug. I show you now a study. This is a randomized phase 3 study of an EGFR inhibitor called osimertinib in patients with EGFR positive non-small cell lung cancer that had the tumor resected. So this is actually given after surgery to prevent the recurrence of the tumor. Since the recurrence is quite high after surgery alone, the use of an additional or adjuvant treatment is considered standard. Here, as you can see, there's placebo as a control because osimertinib is a drug that has very little in terms of toxicity. So in order to be able to know if osimertinib really has a positive effect, then the placebo is required. And here are the survival curves. On top, you can see in blue the survival curve of osimertinib showing essentially a much better disease-free survival, DFS, than the placebo. This is a very large difference. And finally, this is a survival curve of another study where pembrolizumab immunotherapy was compared to chemotherapy in patients with non-small cell lung cancer. The difference between the two curves is smaller than the one I showed you before, but still highly relevant and statistically significant. So pembrolizumab, in fact, in these patients that had a PD-L1 that was high in their tumor, had a better survival than patients that received chemotherapy. So these are 3 examples of successful drugs that were approved by FDA through clinical trials. Thank you for your attention.
All right, thank you, Dr. Giaccone, for that really insightful presentation on clinical trials. I know that he provided some science at the end of it and just how science really informs treatment decisions and why it's so needed. And I think it's so important to make sure that we understand how important clinical trials are in cancer care and in other disease care. And not having access to a clinical trial is a form of a healthcare disparity. And so next we have our Dr. Gina Villani, who will discuss healthcare disparities. Dr. Gina Villani serves as the Chief of Hematology and Oncology at New York Presbyterian Hospital, Queens. She is an expert in studying and providing cancer care and education to low-resource, underserved populations. Dr. Villani will now discuss disparities in the early detection and treatment of lung cancer.
Good afternoon, and thank you everyone for joining us today. My name is Dr. Gina Villani, and I'm the Chief of the Division of Medical Oncology at New York-Presbyterian-Queens. I'm going to be talking to you about disparities in lung cancer detection and treatment of early stage disease. And what I'd like to do is first just describe what is health disparities, what are health disparities, give you a couple examples of some of the cancer disparities as they relate to lung cancer, and then together develop an action plan. So health disparities are defined as preventable differences in the burden of disease and the opportunity to achieve optimal health experienced by socially disadvantaged populations. And we're going to keep hearkening back to this definition as we move forward. I think the key word here is these are preventable differences that are experienced by socially disadvantaged populations. And what we mean by socially disadvantaged populations are unfortunately many different groups. Disparities can occur based on race, gender, sexual orientation, income, geographic location. We see lots of disparities in healthcare in rural areas, education, disability, and ethnicity. And what I think you can gather from this is that an individual person can fall into many of these different groups and thus experience disparities at many different levels. We also know that disparities occur across the continuum of cancer care, from screening to stage at diagnosis to treatment to complications related to treatment to survivorship to death and to quality of life. Patients can experience disparities throughout, again, the continuum of cancer care. So we've made some progress in eliminating these differences in outcomes and other measures among unique populations. And I think we should start with where we've made progress. And where we have made progress is in the rates of lung cancer. What we traditionally had seen was that Blacks experienced more lung cancer and died at a higher rate than whites. And over the past decade, we've really seen that difference between Blacks and whites in mortality from lung cancer decline. And that decline for Blacks has been incredibly steep. And this is felt to be due to the education around smoking prevention, among other measures, such that Blacks who are born after 1967 are no more likely than whites to get lung cancer or to die from lung cancer. So this is progress. However, there's one notable exception, and that is that we're seeing an increase in lung cancer incidence in Black men aged 43 to 48. This is felt to be due to targeted advertising to African-American youth in the 1990s, targeted advertising by the tobacco industry that has led to this age group not being able to experience that decline in cancer rates that we've seen in other groups. And I think this is really, really important because, again, now this has gone away in the future, but we have a new problem to look at, and that is e-cigarettes and things of that nature. And we've got to be really mindful about this targeting to different populations and what is happening with these e-cigarettes. And are we going to see a resurgence now, again, of lung cancer where we've made progress in these different groups? I want to talk about lung cancer screening. And probably a decade ago, there was a trial called the National Lung Cancer Screening Trial, the NLST. The idea of this trial and the hypothesis of the trial was that if we screened folks with low-dose CAT scans, that we could reduce the mortality from lung cancer. So this trial was undertaken. Eligibility for that trial was that you had to be between the ages of 55 and 74, that you had to have a smoking history of 30 or more pack years, and that anyone who is a former smoker would have quit within a 15-year period of enrolling on the trial. And again, the purpose of this trial was to take this high-risk group, people who are at high risk of ultimately developing lung cancer, put them through screening with low-dose CAT scans and see if this would reduce mortality from lung cancer. So the trial enrolled over 50,000 patients throughout the country. Unfortunately, of those 53,000 plus patients that enrolled in this national screening trial, only 4.4% of the participants were African Americans. That translates to an African American enrollment in this very important and pivotal trial of less than 2,500 patients. The conclusions from that trial were that screening with this low-dose CAT scan did in fact lead to a 20% reduction in lung cancer deaths in patients who met eligibility criteria. And from this pivotal trial, from this national trial, we now accept low-dose CAT scan as a screening methodology for lung cancer. But in fact, what does that study really tell us about screening in African Americans and even other racial and ethnic minorities? Does it tell us that African Americans benefit from screening? Does it tell us how much they benefit? I would say no, when in fact there were only 2,500 African American participants in that trial to begin with. The guidelines that were generated from that study, these guidelines that said, okay, we're going to do screening as a means of preventing lung cancer. And the people who are eligible for that screening are folks who are between the ages of 55 and 74, have a 30-plus pack year smoking history, meaning they smoked 1 pack a day for at least 30 years, and that they had quit within 15 years of being screened. That in fact, 32% of African Americans who actually developed lung cancer were never eligible for screening because they didn't fit into those guidelines. Remember what we said, the health disparity is a preventable difference in the burden of disease and the opportunity to achieve optimal health experienced by socially disadvantaged populations. So that those trials that were done that included so few African Americans really created a disparity in that we don't know what is appropriate screening for the African American population. And it's preventable because if more African Americans and minorities had enrolled in that trial, we could have those answers. So what are the mitigation strategies? How do we overcome this kind of disparity? Well, we need to have increased minority enrollment in clinical trials. Clinical trials are the way that we move cancer treatments forward. And if we don't have the appropriate patient population, if we don't have a diverse population enrolled in clinical trials, we're never going to have the answer as to how we treat those unique populations. We need to revisit those guidelines and develop studies and outcomes that are pertinent to underserved populations. And in fact, there are studies coming out looking at screening with a unique to African American populations and trying to develop screening guidelines that meet the needs of that population. And as I had said before, we can't let history repeat itself. we now have a burgeoning of e-cigarette use among young individuals, and we need to make sure that, number one, that we do not allow advertising to target those certain subgroups, as we talked about in that first case of a disparity, and number two, that any studies that we do about the use of e-cigarettes, the risks of e-cigarettes, that we make sure that we include minority populations in those studies. Another area that I want to touch on is to just look at the fact that smoking is not the only risk factor. Indeed, it is a very serious risk factor. It is something that we really need to be working on, and we have made progress to get people to quit smoking. But we have to be mindful that smoking is not the only risk factor for lung cancer. In fact, we know that unprocessed biomass, wood, crops, dung, coal, these things used in burning by half of the world's population are putting people at risk for developing lung cancer. Asbestos, we're all familiar that asbestos is a risk factor for lung cancer, and when you combine it with asbestos and smoking, it really quadruples the risk. We know that diesel exhaust now is a carcinogen, that air pollution is contributing to lung cancer, as well as arsenic and radon. So again, it's not just smoking, although smoking is the number 1, 2, 3, 4, and 5 risk factor, but there are other environmental risk factors that populations are exposed to that increase their risk of developing lung cancer. This is a study from Scientific America in November of 2012 that shows that tiny particles of air pollution contain more hazardous ingredients in non-white and low-income communities than in affluent and white ones. So let's just go back. Again, I've just listed for you that we know that unprocessed biomass, asbestos, diesel fuel, air pollution, arsenic, radon are risk factors for lung cancer. And now we have a study that says that air pollution is more hazardous in low-income and minority neighborhoods. Again, this is a disparity. This is a preventable difference in the burden of disease for a disadvantaged population. How do we mitigate this type of disparity? We have to recognize that health and wellness doesn't just start in the clinic. It doesn't just start at the point of coming to the doctor. We need to understand the social determinants of health, and we need to understand that environmental justice is cancer prevention. Just like tobacco cessation is cancer prevention, just like screening is secondary cancer prevention, environmental justice and making sure that people have clean air to breathe, and that the air that they breathe isn't dependent on the neighborhood that they live in, is a form of cancer prevention. And we need to recognize that and ultimately mitigate these disparities. This is a third disparity. Again, I want to just give you a flavor for what disparities exist in lung cancer. And this is looking at a study of surgical resection of early stage lung cancer. We know that patients who have early stage disease, meaning that the cancer has not spread beyond the lungs or the lymph nodes within the chest, that operating on these people gives them the best chance for cure. And this is a study that was done in 2019 by Tibet and others that showed that disparities in the surgical management of early stage lung cancer, looking at the disparities of surgical management in early stage lung cancer and seeing how far we've come over the past 20 years. Because there was data in the past that said that minority and underserved populations weren't receiving surgery for early stage lung cancer, and that there was a disparity in who was being operated on and who wasn't. So Taboo and others took it upon themselves to look at how we're doing over the past 20 years in eliminating that disparity of allowing everyone who's eligible to have surgical resection of their lung cancer. And unfortunately, what he found was that over the past 20 years, he looked at who got surgical care for early stage lung cancer, and analyze them based on race, ethnicity, income, insurance payer status, area of residence, did they live in a rural population, veteran status, sexual minorities, and actually found that demographic and socioeconomic factors such as race, ethnicity, these special population groups, income, insurance, continued over this 20-year period to impact the receipt of definitive resection. In other words, even over a 20-year period, as far as we've come, we are still seeing that underserved populations based on race, income, insurance payer, veteran status, receive curative surgery for lung cancer less than majority populations. How do we mitigate this kind of disparity? We need to educate physicians and healthcare providers about unconscious bias. And we need to develop rigorous quality control so that this cannot continue. So I just wanted to point out to you, first and foremost, what is a health disparity, and then show you some examples of the unfortunately myriad disparities that exist in our healthcare system. I wanted to show you how where you live affects your risk factors for lung cancer. I wanted to show you that we have yet to really mitigate disparities in enrollment into clinical trials and are working off assumptions that may not apply to diverse populations. And I've wanted to show you that we have to be very mindful of the health that occurs outside of the clinic, such as targeting certain populations to take on unhealthy behaviors, again, such as environmental injustice. Again, just to give you a flavor of the types of disparities that we're currently trying to mitigate in our healthcare system. So we need to have an action plan, right? If we have all of these disparate outcomes and disparities in care, we really need to have an action plan as to how we're going to eliminate them. And I think the medical community must first and foremost, we've done enough describing about these disparities and start doing something to actually make them go away. There's lots and lots of literature that talks about describing the disparities that exist. We need action plans to make sure that they don't continue. We need to make that mitigation of disparities a top priority. We need to foster leaders who understand and are passionate about reversing cancer disparities. We need to enhance research into disparities and develop strategies as to how to eliminate them. And we have to advocate against policies that exacerbate disparities. This is the work that's needed through the medical community. As community members should educate themselves, become an active consumer, so that when you go to the doctor, when you interface with healthcare, that you ask questions, that you advocate for yourself and for health equity, and that you share what you learn with others around you and really become a champion in this elimination of different types of healthcare for different people. And so my words of wisdom to you are that you should remember that you are the customer and that the healthcare system is here to serve you. Don't be afraid to get involved in clinical research. Be more afraid of having lack of representation in trials. Remember, I told you that the National Lung Screening Trial only included 2,500 African Americans. This is unacceptable. We need to get more minorities, diverse, underserved populations to participate in clinical research. Because if we don't, then what is happening is that what we assume is standard of care may not be the right care. And I would argue that not participating is actually more dangerous than participating. And I'd also just like to say that Google does not have a medical degree, that you can't go through the internet and believe everything that you read, and that when you go and try to educate yourself, make sure that you're looking at appropriate sites, at the Mayo Clinic, at New York Presbyterian site. Make sure that wherever you're getting your health information is really reputable sources that give you accurate information. So I thank you for listening. Again, I hope that I've just given you a little flavor for the types of disparities that exist currently in dealing with patients with lung cancer, and gotten you a little bit excited about the work that needs to be done both within the medical community and the community at large to make sure that we have equitable health care going forward. Thank you very much.
Thank you, Dr. Villani, for that very, very important conversation. I know nationally, we've been talking a lot about healthcare disparities, especially given COVID. So to see that also exist in other diseases, it's an important topic that we need to address. So I know that we're a little lengthy this evening, and I appreciate you all for sticking with me, sticking with us during this time. And before we get into our last presentation, I just wanted to highlight some important themes that I'm seeing here. Again, early detection saves lives. It's important to get screened. I'm seeing a lot of talk about patient advocacy, and we have two guests at the end during our panel discussion that will be talking a little bit more about how you can get involved when it comes to patient advocacy in lung cancer research and lung cancer in general. We have clinical trials, super important. Again, not having access to clinical trials is a form of healthcare disparity. Make sure that you advocate for yourself in that sense, that you ask about clinical trials. And diversity in clinical trials is so important. And I think we see that as well. So I know we've been hearing a lot about EGFR and ALK and KRAS. That's a lot of acronyms that we may not know about. So I have the pleasure of introducing our next speaker, who's going to be talking about biomarker testing and what that means in lung cancer. Dr. Ashish Saxena is an assistant professor of medicine at Weill Cornell Medical College and assisting attending physician at the New York-Presbyterian Hospital. He's a medical oncologist who specializes in cancers of the lung and thymus. Dr. Saxena is also involved in clinical research focusing on precision medicine, immunotherapy, remember that word from Dr. Stiles' presentation, and novel therapeutics, as well as laboratory research to better understand this disease. So thank you so much. This is our last presentation, and Dr. Saxena will be talking about biomarker testing in lung cancer.
Hello, everybody, and thank you for joining us. My name is Dr. Ashish Saxena, and I'm a medical oncologist that focuses on the treatment of lung cancers. Today, I'm going to be talking about biomarker testing for lung cancer. So what is a biomarker? The National Cancer Institute definition is that a biomarker is a biological molecule that can be found in blood or other bodily fluids or tissues that is a sign of a normal or abnormal process or of a disease or a condition. So these are things that we can test for in someone's body that might give us some information about their normal functioning or of a disease or a condition that they may have. The biomarkers may also be used to see how well the body responds to a treatment for a disease or condition. And in lung cancer, we often do use biomarkers from a patient's tumor to help decide if they will respond well to certain treatments. Now, these biomarkers are often specific DNA mutations that the tumor has, but these are not mutations that the person was born with, so not hereditary mutations. Mutations are some form of genetic aberration. The biomarkers can be detected from a tissue biopsy sample or from a blood sample, and they're used for targeted or personalized therapies. Currently, most biomarkers in lung cancer are used to help pick treatments for patients with stage 4 or metastatic disease, where the cancer has progressed from just being in the lung to spreading to other places. But that may be changing, as we'll go into some studies that suggest that biomarkers can be useful for treating patients with earlier stages of disease and possibly increasing their chances for cure. So when we talk about targeted therapy in oncology, our goals are to develop new anti-cancer agents with better targeting of the cancer while sparing the rest of the body, with less side effects, and with an improved activity against the cancer. We want to individualize the treatment to target patients with the greatest potential for benefit from a specific therapy, while sparing people that may not have a good benefit from getting that drug. So in non-small cell lung cancer, which is the most common type of lung cancer, we often talk about driver mutations as biomarkers. So a driver mutation is the main genetic aberration that drives the cancer to grow, and is such that blocking the effect of that mutation can block the growth of the cancer. And shown here are different types of driver mutations that are seen in different types of lung cancer or non-small cell lung cancer, specifically adenocarcinomas and squamous cell carcinomas. So these here are the different types of driver mutations that we know of. In red, I've circled the driver mutations that we already have FDA-approved drugs for, including EGFR sensitizing mutations and ALK mutations. And in blue are some mutations that we may not have drugs for yet, but we have clinical studies of newer drugs that are very promising to target these biomarkers. An important thing to note is that many of these driver mutations are more commonly found in never or light former smokers. And also the EGFR mutations specifically are more commonly found in Asians with lung adenocarcinoma. This can be around 50% in some studies. So that brings us to an important point about risk factors for lung cancer. So I think we all know that smoking is a risk factor and accounts for the majority of lung cancer cases, but never smokers can get lung cancer too. In one study, 9% of men and 19% of women with lung cancer in the US were never smokers. And about 60 to 80% of Asian women with lung cancer are never smokers. So some of the other risk factors for lung cancer are radiation therapy, which might be given to treat other cancers like breast cancer or lymphomas, environmental toxins such as secondhand smoke, the family history. Even though the mutations we're talking about are not hereditary, having a family history of lung cancer may increase your risk, and also other diseases such as pulmonary fibrosis and HIV infection. Fortunately, we have a number of targeted therapies currently available in non-small cell lung cancer, as I mentioned. These are listed here, and this list gets bigger all the time. All of these drugs are oral therapies, so they are taken by mouth, usually in a pill form. And they're currently approved for stage 4 non-small cell lung cancer. Now, they each target different genetic mutations, but the way to know if one of these drugs is appropriate for a patient is to test for the specific genetic mutation, because that will predict whether the drug will be efficacious. And because of this, it's now standard to test for mutations in most newly diagnosed stage 4 non-small cell lung cancer patients. And this is one of the way we do that. This is a comprehensive gene mutation panel, which we use here at Weill Cornell Medicine. And it looks at different types of mutations in different types of genes, which may give us information about what drugs might be efficacious and what might predict prognosis in a particular patient. So targeted therapies in non-small cell lung cancer can be very effective. This is a case of a patient that had a ALK mutation positive lung cancer shown here. They were given a targeted therapy that works against ALK mutations, crizotinib, and after 6 months, you can see a major improvement in their lung cancer. Now, crizotinib is an older drug, and this graph shows that we've made a lot of progress in our targeted therapies. Newer generations of ALK inhibitors, in this case, the drug alectinib, often work a lot better than the older generation drugs. So here in this study, they compared crizotinib to alectinib and found that the overall survival was better with alectinib compared to crizotinib. And the 5-year survival rate of patients on alectinib was 62.5% compared to 45% with crizotinib. EGFR inhibitors also have newer generations of drugs. And this is a study looking at a newer generation EGFR inhibitor, osimertinib, and comparing it to older generation drugs. And here again, you can see the newer generation drugs have a better survival rate than the older generation drugs, showing that we continuously make improvement in our drugs. So everything I've shown up until now has been focused on patients with stage 4 non-small cell lung cancer. But what about earlier stages of disease and targeted therapies in this arena to try and increase the chances of cure. Recently, a study was published called the ADAURA trial, and it looked at patients with stage 1B, stage 2, or stage 3A non-small cell lung cancer, not stage 4. These patients all had EGFR mutations and were treated with surgery and may have had chemotherapy as well afterwards. So after all this treatment was done, the patients either got osimertinib daily or placebo. And what they were looking for was the disease-free survival, so the amount of time that the patients were without any evidence of lung cancer, specifically those that had stage 2 and stage 3A. And this graph here shows that the patients that got the osimertinib, again, all of these patients had this EGFR mutation, these patients had a longer disease-free survival than patients that received placebo. And this is, again, in early stages of lung cancer. So in conclusion, important points to remember are that biomarkers can tell us if a patient's lung cancer will respond to a particular therapy, or at least has a higher chance of responding to that therapy. In lung cancer, these biomarkers are typically genetic mutations or genetic aberrations that the cancer has, but not that the person was born with. These are things that the person develops during their lifetime. Testing for specific mutations is now standard for patients with stage 4 lung adenocarcinomas, which is the most common type of non-small cell lung cancer, but we often do this as well for other types of lung cancer. There are several FDA-approved drugs that target specific biomarkers, and many of these biomarkers are more commonly found in never or light smokers. So again, important to remember that people who don't smoke can still get lung cancer. EGFR mutations are a specific biomarker that is more commonly found in Asians. And the targeted therapies we have right now in lung cancers are currently approved for stage 4 disease. However, osimertinib, which is one of the EGFR inhibitors, has been shown to strongly improve disease-free survival in patients that have stage 2 and stage 3A EGFR mutated non-small cell lung cancer after surgery. Now, this could mean that it will improve the overall cure rates for these patients. And as the study matures and other studies are reported, we may find this to be true. So therefore, it is important to test for EGFR mutations even in early stage patients, because this may in the future lead to using these targeted therapies in earlier stages of disease to improve the cure rates. So thank you very much for your attention.
All right, thank you so much, Dr. Saxena, and for presenting biomarker testing. I hope that everyone got a good sort of overview on what that means, and importantly, just how that shows up in non-smokers who develop lung cancer. So I'm gonna ask all of our panelists to turn on their cameras, and we'll get started with the Q&A session. I want to thank you all so much for still sticking with us. I know it's getting very late, but we are happy to take some questions. So I think the first question, and we have 2 other people joining us this evening, Kristen Santiago and Nikki Martin. So I just want to introduce them very quickly to you all in case you have any questions for them. And so let me just get this up. Sorry, my apologies. All right, so Kristen Santiago, is the Senior Director of Public Policy Initiatives at Longevity. In this role, she oversees Longevity's public policy activities, including how the organization works with policymakers in the federal government and policymakers in states around the country. Thank you for joining us, Kristen. And Nikki Martin is Director of Longevity's Precision Medicine Initiatives. In this role, she oversees the work that Longevity does to increase patients' access to biomarker testing. So what Dr. Saxena talked about, the first step for patients in increasing the benefits of precision medicine. Thank you for joining us, Nikki. So kind of along those lines, we did get a question just about one's risk of developing lung cancer if they are a never smoker. And let me just get the exact question. I do apologize for that. You know, when you go live, this is what you have to deal with, all the little tech issues. So let's just see. So someone asked, am I at increased risk if my parent, who was a non-smoker, had lung cancer? And also, do I meet the screening guidelines? And beyond smoking, what are the other risk factors for lung cancer? So I think we can divide this up a little bit. And Dr. Stiles, would you like to take that question? If someone who may be at increased risk if their parent was a non-smoker and had lung cancer, are they at increased risk?
Yeah, I'll take it first. It's a great question. Thanks to all the panel for joining, especially to the group from Longevity who's done a lot of great work in the areas that we talked about. It's a tough question. We don't actually know all the risk factors for lung cancer. I personally believe that there is probably a genetic component, a heritable component, but it's not like breast cancer where we know that there's a BRCA gene that's associated with it. It's probably multiple genetic changes that may contribute to just an environment in which lung cancer can flourish. We know that some ethnicities are predisposed to lung cancer and never smokers, again, suggesting that there's a genetic predisposition. But it's tough to work out. It's important to point out that right now in screening, we don't have screening options for never smokers. A lot of the advocates in the community are people with never smokers who have these mutations, and they really want us to do screening in that population. I've long maintained that we have to do a better job in the population that's already approved for smokers of a certain age group, where we know that there's a benefit based on large randomized studies. I think once we get to routine uptake in that group and show that we can do it well and safely, then we'll be able to expand it and start looking for other biomarkers in other populations who maybe aren't as at risk due to smoking alone.
Thank you for your answer there. I know that this question was already answered in the chat, but I just wanted to bring it up because I think this may be a concern from others about just marijuana smoke. And how does secondhand marijuana smoke compare to cigarette smoke as a risk factor for lung cancer? Dr. Saxena, can you answer that question for us?
So in terms, I think Dr. Stiles may have answered, in terms of marijuana smoke, I don't think it's, correct me if I'm wrong, Brendon, as carcinogenic as the cigarette smoke, secondhand smoke. We know secondhand smoke, cigarette smoke is definitely a risk factor for lung cancer. But I don't know how much is known about the marijuana smoke specifically.
Thank you for that. So the next question, I want to just shoot over to Nikki for a second. So Nikki, so as someone who works for Longevity, and this is a question that I have, a patient advocacy organization. So, you know, we know that not all patients may get biomarker testing. Could you give us an idea of why that may be?
Sure. And first of all, thank you very much for including Longevity, me and my colleague Kristen in this event tonight. It's been spectacular with all the doctors and providers providing their feedback for everyone. So when we think about some of the reasons why biomarker testing isn't performed on all advanced stage cancer patients, we've, as an advocacy group, and I think other people on the phone would on this call would probably agree that, I mean, there's lots of reasons why biomarker testing isn't being done for all patients, but it falls into a couple of buckets: awareness and education, among the providers, the doctors, and also awareness and education among patients and their family members to know that they should be asking for it. So in an ideal world, they wouldn't need to, right? But still, we would like to increase kind of the awareness and education among patients so that they know they need to ask for it. And then there's a couple other reasons that are outside of awareness and education and are more along the lines of sometimes there isn't enough tissue that is taken out of the lung for the biopsy, from the biopsy that makes it to the lab for testing, and that can be a barrier to testing. And sometimes some of the way that the tissue is handled in the laboratory might end up being a barrier to having enough tissue to perform the right kind of testing. So there's a couple of reasons why testing might not be done, but when we're talking about the people participating in today's event, we really want to encourage everyone to ask their doctors to make sure that they have comprehensive biomarker testing performed, because it's so important to understanding more about your specific kind of lung cancer.
Thank you for that. And you know, it's that the awareness piece of it is so important. And again, not everyone who, if you're not in the space, you may not be aware that this even exists and the importance of it being done so that there are targeted therapies to help you if you were to develop lung cancer. Kristen, along these lines, so I know that longevity, and again, it's the question that I have, is very interested in understanding how insurance coverage may help or prevent people from having access to biomarker testing, which is, you know, crazy to think about that something like this is not accessible to everyone. Can you share a bit about the lung cancer scorecard and what you found in New York specifically?
Yeah, absolutely. So, and thank you again for including longevity in this event. So Nikki talked about the awareness issues and then the kind of technical aspects, but there's also the big issue around payment, who's going to pay for this type of testing. And depending on an individual's insurance status or where they live may or may not mean they have access to precision medicine and to biomarker testing. Longevity did a report card or a scorecard in February of this past year, and you can access it at lungcancerscore.org, and we can put it up in the chat. But that looked at how people with Medicaid insurance were accessing optimal care. And one of the things that we looked at was, did Medicaid in different states cover biomarker testing? And unfortunately for people in New York, which is incredibly relevant to the individuals, you know, on this call, webinar, whatever today, Medicaid in New York does not cover biomarker testing. So what that means is that someone, just because of their insurance status or because they live in New York versus another state, will not have access to this type of testing that can really save lives and really change the treatment options that are available for people. So I encourage you to look at it. And I'll just say that Longevity is working on a policy angle to try and change the Medicaid coverage policies. And we invite you all to kind of jump on board with us. And we're holding a briefing in the next, 3 months in New York to try and work with state legislators to educate them about the importance of precision medicine. So I hope to work with you all on that, because it's not okay, right? It feeds off of the health disparities presentation. It gets me pretty fired up. I hope you guys get fired up too.
Thank you for that, Kristen. And I think that, you know, it's again, it's a shame that this isn't offered, that if you're on public insurance, you may not have a chance or access to this life-saving testing. So yes, the Meyer Cancer Center will be working with Longevity on these important systematic barriers to access. And we look forward to working with you. Dr. Villani, I have a question. You brought up just the importance of advocating for your own health. And I think sometimes people don't know how to do that. So, you know, we may think that doctors are a little intimidating. We don't know the right words to say. So could you give some advice to people who may be struggling with how to advocate for their own health and speak to their doctors about their own health?
Yeah, I mean, first of all, I think never say whatever you say, doctor. And unfortunately, I just hear that all too often. People come in and I start to talk to them and they say, no, you're the doctor, whatever you say. I think you just have to insist that people explain things to you in a manner that you can understand. And I don't think that's a difficult thing to do. I think you have to ask a lot of questions. You know, this forum tonight hopefully gave people some information about the kind of questions they should be asking. What kind of lung cancer do I have? What is my stage of lung cancer? What does my biomarker panel look like? What is the treatment plan for me? I think, you know, it's just really opening up that communication with your doctor and not being afraid to say, I don't understand what you said. You've got to explain this to me in a different manner. Because I don't think you can ever go to an appointment just fully charged with every question that, you know, you need to ask. But I think just the fact of saying, again, I am the consumer and you need to be explaining to me what's happening to me.
Thank you. Yeah, and that's really important. I think that, you know, just emphasizing if you don't understand something, you need to make sure that you leave that room understanding to the best of your ability. Just don't say whatever, doc, because it's important to, again, advocate for your health. Samantha, you brought up this word or this term that you said shared decision making when discussing lung cancer screening at Weill Cornell Medicine. Could you talk about what does that mean for people?
Sure. So shared decision making should really ideally occur before every medical decision that a patient makes. But with lung screening, it's particularly important because patients really have to understand the benefits of screening, the potential limitations of screening, because there are certain populations that we know lung screening benefits the most right now. So the shared decision-making process is really just a conversation to have. So patients really understand, the process of lung screening, and it really establishes a relationship, which we love to have with our patients. So they know that they're not alone throughout the process, because it can be scary and create a lot of anxiety. So it's really to establish that connection with the patient as well.
Thank you for that. And lastly, I just want to ask a question to Dr. Giaccone. I know that, the talks of clinical trials lately, as we're thinking about the COVID vaccine and just the word clinical trial has been, or clinical research has been in the news so much. And I think there may be some anxiety around that in participating in clinical trials. But from these presentations, we know it's important to participate in clinical trials. It's part of science. So to those who may be a little apprehensive about participating in a clinical trial, could you just let us know sort of what is done on the back end to ensure that patients are cared for appropriately? Could you just, touch upon regulatory things that may be in place to ensure that clinical trials are carried out to ensure the safety of patients? You're on mute, Dr. Giaccone.
There we go.
Now we can hear you.
So actually, there are studies that looked at how patients did when they were clinical trial and how they did those patients that were not on a clinical trial. And in general, survival is better when patients are treated on a clinical trial. And the reason for that is very simple. When you are on a clinical trial, everything is done what is possible to make sure that what you are undergoing is safe. And so some extra measures are taken to make sure that, that the risks are minimized. Of course, there's always an experimental part of taking part of a clinical trial. So there is always some risk, but the risk is also there when you don't participate in a clinical trial. And the clinical trial really gives people access to new things that may be extremely promising that you would not have for maybe another year or two before they are approved by FDA. So this is a very important process. And when I see patients, I usually try to provide a general understanding of where the state of the art is and what can be achieved by participating to a clinical trial. In terms of, some people may be skeptical. In fact, the question I receive the most is, am I going to receive a placebo? Or am I going to receive just sugar or water? When that is the case, actually in oncology, that doesn't happen that frequently anymore. But when that is the case, this is clearly disclosed, of course. And when that is done is really because the difference between the new drug and placebo may be very small in terms of side effects, for instance. So then you really need a placebo to make sure that if you see side effects, it's really the drug and not just by chance. When you treat somebody with anything, you may see things that look like side effects, but they may not be. So it is important really to control for that as well.
Thank you so much for that, Dr. Giaccone. So we are going to wrap up, and I sincerely thank all of you for sticking around this late into the evening. I want to thank our panelists. Before we go to our raffle, I want to thank our panelists, Dr. Gina Villani, Dr. Brendon Stiles. Brooke, I'm not going to send any questions your way. She was with us last night. Dr. Giuseppe Giaccone, Kristen Santiago, Nikki Martin, Samantha Vigada, and Dr. Ashish Saxena. Thank you all so much for sharing your expertise and speaking with us about lung cancer. I think after this evening, we can see that it can be curable with treatment, and early detection, again, is a really important part of that. We are getting some questions, just general questions that I want to address. These recordings will be made available on our YouTube channel. And if you scroll up into the chat, there is a link to our YouTube channel that will be made available in a couple of weeks. I will also send an email out with this information as well. We also have programming tomorrow in Spanish. There's a link there, and programming in Chinese. I'm going to just drop the link right there. And the moment that you've all been waiting for, I'm sure, we are going to announce the 3 winners of our raffle. So I'll say the first initial, last name. The first is A. Downs. A. Downs, I have your email address. I'll be in touch with you. The second person is D. Vaz, V-A-Z, D. Vaz. I'll be in touch with you as well. And then we have S. Chi. S. Chi. I will be in touch with you via email. And if you won the raffle a couple nights before, I will also be in touch with you via email next week. Thank you again to everyone for joining us, and have a wonderful night. Oh, I'm sorry, one last question. I know that someone asked about sites in Staten Island. Unfortunately, we do not have any sites in Staten Island, but if you scroll up to the beginning of the chat, you'll see, I think the closest may be Lower Manhattan after you get over the ferry, will be there. So there are, you can connect with providers there as well. So thank you to everyone for joining, and have a great evening. Take care. Bye.
Thanks, Kelly. Bye.
Thanks, everybody.